Thank you very much to involving me in this uh, very warm house of friends and such high-profile colleagues. I really thank you so much. It's an honor for me to meet you again since a long time of knowledge. We share our experience in a COVID era by using webinars and online meeting. The topic comes from personal experience, but also from day life and day life professional experience. All of us faced with Chiari malformation directly or indirectly. And first of all, we have to underline the right updated vocabulary in order to define this challenging condition. So far, since Chiari and Arnold very first communication, we have 5 types of Chiari malformation. Type 0 is just a small posterior cranial fossa without tonsillary herniation, without syrinx, but with some symptoms related to. Point 5 Chiari is just Syringomyelia. Type 1 Chiari is complete or partial herniation of cerebellar tonsils at least 3 or 5 millimeters below the foramen magnum. Type 1.5 as a tonsillary herniation along with the odontoid retroversion, and this is for us, for craniovertebral junction spine society members, one of the most interesting and available for our surgical skill. Type 2 is a tonsillary herniation with spinal dysraphism and hydrocephalus, so-called also Arnold Chiari in pediatric age. Type 3 is occipital cervical hernia. Type 4 is aplasia or hypoplasia of cerebellum. This is a Goel definition of Chiari malformation, and we all should be fast to accept and to make this definition the true definition of Chiari malformation. Chiari formation. That means that Chiari is a phenomenon, a pathophysiological mechanism that proceed from the beginning to the end of the pathological formation. The difference between Chiari 1 and Chiari 2, in other words, from Chiari and Arnold Chiari, is the age of presentation, young adult for Chiari 1 and infancy for Chiari 2, and the association of spina bifida and hydrocephalus always present in Chiari 2. This is a very challenging and a rare condition of Chiari 3 malformation with a high cervical and suboccipital encephalomeniнгocele, which is the etiology of this quite obscure pathology. Number 1 is posterior cranial fossa small. Number 2 is hydrocephalus of the driving force of craniocaudal pressure cone. Number 3, craniosynostosis. Number 4, abnormality of the upper cervical spine, such as C1, C2, hypermobility, Kippel-Feil syndrome, occipitalization of the atlar, basilar invagination, and finally, arachnoid fibrosis around the tonsils. Most interesting clinical and pathophysiological condition is the small posterior cranial fossa. As you can see here, this is the primary driving force for a turbulence in posterior cranial fossa and craniocaudal pressure cone that exudate in Chiari malformation. When to manage and how to manage this challenging condition. Number one, who is the Chiari patient to be considered by a spine surgeon? The one who has symptoms. This is the answer. When? When symptoms are present and progressive. How? Especially in three different ways. Number two, suboccipital craniectomy. Number one, suboccipital craniectomy. Number two, with suboccipital craniectomy and dural opening. Number three, suboccipital craniectomy, dural opening, and manipulation of arachnoids and local intradural anatomy. And these not only for treating sensory motor deficit, but also for treating neuropsychological function, sometime, but not so rarely, associated with the clinical picture. But let's move to the surgical strategy and start with suboccipital craniectomy. This is the most worldwide surgical procedure used so far, or in a successful way. 2 centimeter long and 2.5 centimeter wide suboccipital craniectomy, along with C1 laminectomy, with or without dural delamination. The results between the dural delamination cases and the dural sparing cases are quite the same. And anyway, suboccipital craniectomy and linear incisions of one of the two lamina of the dura is a very promising surgical procedure. Second technique is a craniectomy and durotomy with arachnoid preservation. We means durotomy, not laminar or delamination of the dura. And in this book, where we collected the experience existing so far about craniovertebral junction surgery in this paper, we approached the topic with linear durotomy with a complete sparing of the arachnoid, have a surgical strategy of Chiari malformation. We can have sometime intrafascial CSF leakage that solves spontaneously. Third technique is a craniectomy and dural patch. No doubt that this is well known and well used all over the world, and the dural patch is made with autologous, heterologous, or a synthetic material. Then we have the fourth strategy: craniectomy, tonsils coagulation, arachnoid debridements, obex opening, and dural patch. And in this paper, we showed how important is the intradural membranes, veils, pouch removal, and fourth ventricle exploration in order to restore CSF circulation and then close such an approach with dural patch. When we speak about dural opening, we have to consider that in 50% of these patients, syrinx disappear, and in more than 50%, we have an improvement of a clinical pattern of this patient. Surgical technique for intradural and debridement, internal debridement, and full ventricle exploration is different from different school, but microsurgery is the key, and all we have to do is try to restore posterior cranial fossa and cisternal circulation in order to significantly lower recurrence rate of Chiari malformation. Nevertheless, CSF fistula occurs in 6% of all the cases treated. And transoral transnasal decompression, posterior instrumentation infusion is a key when we deal with basilar invagination, which is the most common adult craniovertebral junction malformation associated with Chiari. In this paper, I tried to show in pediatric age what happened when we deal with basilar invagination and Chiari malformation, as in this patient, which is a patient harboring Chiari 1, basilar invagination, bulbomedullary junction dysfunction, and this patient underwent to transoral decompression. Look at how high we can go with transoral by removing the synchondrosis of sphenoid and clivus, and that is the reason of my comment to the wonderful lesson of Mehmet Zileli. With the surgical way, you know better, we can do more than consider and previewed and possible with this way. The Chiari disappear along with the anterior cranial fossa decompression, but some months later on, the odontoid start to regrow, the clivus start to regrow, the Chiari malformation, again Chiari formation as tonsillary herniation start to represent up to complete recurrence of a clinical pattern with a quite complete regrowth of odontoid and clivus. And the surgical strategy in this case was just to decompress by posterior approach. And now we move to the most important message that Atul Goel gave us. C1, C2 instrumentation infusion when dealing with the Chiari formation. And this is his paper in the book of craniovertebral junction surgery of 2 years ago. And in this paper, as in many other following papers, Atul shown us that Chiari Chiari formation along with the bulbomedullary junction symptomatology disappear soon after C1, C2 instrumentation infusion according to the technique he taught us. Then we move to syringostomy and syringe shunt strategy for those cases associated or not associated with tonsillary herniation. Syringomyelia was classified in four types. Type 1 is related to foramen magnum and engorgement, crowding of posterior cara fossa, as in A, in B, with the other lesion of foramen magnum. Type 2 is syringomyelia without foramen magnum dysfunction. Type 3 is syringomyelia associated with spinal cord tumors, traumatic myelopathy, arachnoiditis, myelomalacia. Type 4 is pure hydromyelia. And syringomyelia without tonsillar ectopia is a challenging condition associated with a posterior cranial fossa abnormalities without tonsillary herniation. The mechanism is the same. The CSF flow impairment is the same. The distortion of posterior cranial fossa is the same. The our crowding of posterior cranial fossa is the same of tonsillary herniation, but in these cases, tonsillary herniation still not happens, still not pop up. And in this case, with symptomatic, surgical strategy is mandatory. Just to remind, the association of Chiari and Syringomyelia has a genetic component in well-selected groups of families, which is the therapy, the surgical therapy for Syringomyelia is shunt, cystoperitoneal shunt, or cystopleuric shunt. Many techniques, different strategies, but the same aim, just to decompress the cyst and to allow the cyst to drain in a cavity in case the cyst continues to be refilled by the pathophysiological mechanism that we have identified. Microsurgery is the key. Then we have the final topic of this presentation, the treatment of Chiari depending from hydrocephalus, craniosynostosis, tetracord, and idiopathic intracranial hypotension. Let's move to hydrocephalus. Very simple clinical picture. A child, 9 years old child, with a well-drained hydrocephalus. Everything is good. When shunt when the patient has a shunt malfunction, the Chiari formation and Syringomyelia are not Chiari syndrome pop up again. So restoration of CSF drain is the key, and the disappearance of Arnold Chiari is quite immediate. What about craniosynostosis, which is a classic pediatric neurosurgical entity? The very early fusion of cranial surgery is the explanation for a posterior small cranial fossa. We have to restore CSF circulation. We have to reopen circulation at the basal cistern. So surgery and craniectomy is the key. What about tetracord? As we know, tetracord is associated with normal size posterior cranial fossa Chiari malformation. And there is a Spanish well-known neurosurgeon who pushed so much to claim for a patient to operate, sometime not always harboring a true tetracord, but the technique that he proposes is very simple, a circular laminectomy of C1 extended to C1, C2, C3, C4 laminectomy, identification of filum terminalis, and extradural resection. There is a great deal of interest, economic interest for this strategy. The Italian Society of Neurosurgery wrote a paper against this worldwide growing mood of surgical treatment. And now we move to the last clinical picture, the idiopathic intracranial hypotension. Very strange condition, bad known condition of a reduction, idiopathic sometimes, secondary mostly of the time, CSF pathological drainage. So as a consequence of this condition, probably triggered by a trauma, triggered by a malformation, we have an epidural CSF collection that we can identify with the MRI, and this collection can be along the nerve roots, and there are multiple sites of leaks. Which is the treatment? Conservative, bed rest, caffeine. Surprisingly, caffeine can be the cure, or epidural blood patch, or fibrin glue patch, or surgical occlusion with dural patch. Anyway, the brain imaging pathognomonic for this very original condition is the presence of subdural fluid connection, mostly hygromas, or enhancement of pachymeninges, or engorgement of venous structure. You see the venous sinus enlarged, like a depressing secondary reaction to this noxa, pituitary hyperemia, and mostly sagging of the brain, descent of cerebral tonsils, and flattening of the pons, bowing of the optic chiasm. In conclusion, natural history is complex. Asymptomatic patient claim a wait-and-see strategy. Symptomatic patient claims a surgical strategy. About recurrence, the lower recurrence rate were found for decompression with arachnoid opening, mostly efficacy. And this is an unofficial conclusive sum of consideration made in occasion of the Italian Consensus Conference of 2019. These are so far unpublished data. In adult with Chiari and Syringomyelia, the best is a duroplasty, and a watertight closure prevent CSF leakage. Finally, and so we conclude this brief presentation, to review Chiari malformation papers may be so far a real challenge. Thank you so much for your attention.